त्र्यम्बकं यजामहे सुगन्धिं पुष्टिवर्धनम् उर्वारुकमिव बन्धनान्
So first of all, I would like to heartily welcome everyone who has joined this very, very important and I should say a very exciting webinar of in obstetrics, art and science of birthing. And anyone who loves obstetrics the way I love it, and I think Dr. Haresh sir also loves it, we are definitely planning to have good discussions and which will leave everyone wanting for more. So I welcome today the chief guest, Professor Gangadhar Sahoo, who is the president of National ISOPARB, and Dr. Haresh Doshi sir, who is a teacher par excellence. I welcome Kiran. Kiran will join later, and I welcome all the other faculties, Dr. Manju Varma ma'am, and all the other faculties and delegates who have joined. So for a welcome, Dr. Kishore. So nice to have you join this exciting webinar of ours. Professor Gangadhar Sahoo is President ISOPARB. He is retired professor and HOD Obstetrics and Gynae VSS Medical College, Burla. Dean IMS and SUM Hospital and Pro VC SOA. His dream, this is wonderful, to be a ladder of success for others to climb up. An ordinary man surrounded by extraordinary friends and well-wishers. Welcome, sir, and please give your blessings to this August gathering.
So, blessings from Lord Jagannath and Ma Samaleshwari. Greetings from ISOPARB. So, my namaskar to all the members of Prayagraj chapter of ISOPARB. At the same time, I welcome all the dignitaries who are present here, all the speakers, chairpersons, on such a beautiful topic. That is a challenging topic in modern obstetrics, I can say, the art and science of birthing. So to say a few words regarding ISOPARB, that ISOPARB is a chapter which is moving very fast and it has had its momentum for last 2 years. And Prayagraj chapter is one which is feeding its fuels for the motion of ISOPARB. So therefore, my thanks and congratulations to the chapter of Prayagraj and all its members. Madam, I can say that let us walk the talk is the motto of our tenure this year. So we'll work more and talk less. So second thing is about Prayagraj chapter, that it is what I have felt. I think I have been associated with this chapter very few occasions. But what I have gathered informations and I have felt myself from the pulse of Prayagraj ISOPARB chapter, that it is a vibrant chapter. Very often they are having webinars, even physical meetings, webinars connecting, very innovative way of connecting with other chapters, even far off chapters, to spread the message of ISOPARB. Once again, thank you very much, madam.
Thank you so much, sir, for joining.
Regarding the topic of selection, I can say, so nowadays in modern obstetric practice, as the science is developing, the art that is gradually declining. So the tools of obstetrics and the art of vaginal birth, may it be through maneuvers, may it be through instrumental delivery,
मीटिंग में हूँ,
they
15
will
मिनट बाद खाली होंगी तो
become
आपके
a history in future. But to revisit those things, to revive those things, is the duty of the stalwarts like you, madam, and sir, was present here. So I wish your chapter a progress. Very good luck to you, madam, and wish all the best and your members of the chapters. With this, I can say, long live ISOPARB, long live ISOPARB, long live ISOPARB. Thank you, madam. So let us feel after this discussion that the vaginal birth is not a vanishing art. Thank you very much.
Thank you so much, sir. And Amita, I think you take over.
Thank you, ma'am, and thank you, Sahoo sir, for acknowledging ISOPARB Prayagraj efforts. Thank you so much. With this, we are moving towards our scientific session. And today, again, we have a very interesting topic, occipito-posterior position in labor. And we have none other than Professor Dr. Haresh Doshi, who is in quite a demand in our society and all the various societies. Welcome, sir. And to chair the session, we have with us Professor Dr. Manju Varma, ma'am. She is a teacher of the teachers, my guru. She has been president of Uttar Pradesh Obstetrics and Gynecological Society, HOD of Maryland Medical College, and well, she's a guiding force and we can say a founder pillar on which AOGS stands. And our next chairperson is my very dear friend, charming Dr. Chitra Pandey. She is nowadays Vice President ISOPARB, Vice President of AOGS, Chairperson of Women's Doctors Wing of IMA Prayagraj. And I welcome Dr. Chitra. And please, Dr. Chitra, kindly introduce Professor Doshi, sir.
Good evening. And first of all, I wish everyone a very happy Eid and Akshaya Tritiya. Today, I am very happy for two reasons. First of all, I am chairing this session along with Dr. Manju Varma, ma'am. And the other reason is that I am introducing Dr. Haresh Doshi, who is itself from Ahmedabad, and everybody knows that I have a very special connection with Ahmedabad. I did my post-graduation from there. I have so fond memories of Ahmedabad that I can never forget. So I welcome you, sir. I'm so happy that I'm introducing you. Dr. Haresh Doshi, sir, is Professor and HOD of Obst and Gynae in GCS Medical College, Ahmedabad, Gujarat, with a very vast experience of teaching, more than 36 years. Sir has written many books and booklets, and he has many publications to his credit. He has been faculty in more than 220 national and international conferences. Sir has also been president of FOGS 2003 and president of CHAIRPERSON in 2004. And he has given his valuable contribution to FOGSI in various cities. Like he has been vice president of FOGSI 2019, organizing chairperson of HRP-CON, and sir is ICOG governing counseling member 2021 and 2022. So we welcome you, sir, and we are very keen to hear you. Please, I invite you to start your lecture.
My respected chairperson, respected Manju madam and Dr. Chitra madam, founder president Dr. Ranjana madam, chief guest Dr. Gangadhar, secretary Dr. Amita, Dr. Saida madam, Subha madam, Utsa madam, respective presidents of Faizabad, Allahabad and Kanpur society, and all office bearers. First of all, I'm extremely thankful to Ranjana madam for inviting me and also allowing my topic to speak. She told me, what will you speak? I told madam that I will speak occipito-posterior. It is my favorite topic from years. Okay, I'm not going to tell you something new, but what is happening and what should be done, that some tips will be good for take home. I asked my students, which are the three most difficult presentation in obstetrics? Occipito-posterior, 1. 2, occipito-posterior. 3, occipito-posterior. Bottom line is important. Occipito, it is even in Mundrokar. occipital posterior causes more all the malpresentation put together. And now it is true because all malpresentation just we require to diagnose. We do cesarean section straight away once we diagnose. But in our times we were giving trial of breach and all that. Nowadays gone. So occipital posterior still stays because it's a vertex presentation. Well, you know all this that it is occurring in 10 to 15% of vertex presentation at the beginning of labor. Right occipital posterior is 5 times more common than left occipital posterior because of sigmoid colon there. Out of them, as we know, up to 90% will rotate. That is, only 1 to 2% will cause you real trouble in labor. But that which 1 to 2% is difficult to make out. The problem is there. It is difficult to diagnose before late second stage of labor, which 10% that I mentioned, 1 to 2% of all 100 cases will not rotate and will get arrested. So this is simple. For diagnosis in late pregnancy, we usually do standard teaching. When we examine the patient after 36 weeks, flattening of the abdomen below umbilicus, limbs easily felt on both sides of midline, anterior shoulder far lateral in the flank, both sinciput and occiput felt at the same level when you go for rule of fifth, palpation from above because of deflection, and they are at a higher level because there is always a delayed engagement. But all this is for UG clinical teaching. What is there now is when we do USG in last weeks of pregnancy, we can have in our mind that this patient is having occipital posterior. So nowadays this teaching will change in next textbook. It may not be required at all. Same thing, ultrasonography not in few days of pregnancy, last weeks of pregnancy. Also in labor, you can use that if you have a doubt in diagnosis. And that ICOG has clearly mentioned ultrasound assessment of the fetal head position is recommended where uncertainty exists following after clinical or abdominal per vaginal examination. So it is now a handy tool if we should have it in our labor room and then we don't have in a trouble. Now, management, because it is occipital posterior in labor, that was the topic. No antenatal management. In our times, we used to teach that lying left lateral on opposite side helps, knee right position or that position helps, but that is proved by evidence that it does not help. In labor, what is required is watchful expectancy as 90% rotate to anterior. You have to do routine first stage management. What is the deviation from that routine? Bed rest is advised even if there is no rupture of membranes, because if the patient gives ambulatory, there are more chances of early rupture of membranes because the flex head does not feed the cervix properly. So membranes balloon out and rupture. But if it is already there, then you always give bed rest to the patient. Prevent premature bearing down because now occiput is posterior, the posterior vaginal wall, rectum is pressed more during labor and the patient starts, if she's a Paris patient, she knows that by pushing the baby comes out fast. So she starts premature bearing and that is wrong. So what required in a labor that you don't know which will get arrested. So full preparation ready for cesarean section. That is simple. Now, these are well accepted and well experienced by us. Labor characteristics of occipital posterior. Slow progress as compared to vertex anterior and any other same parity patient. Delayed dilatation of cervix. Incoordinate uterine action. Ab thak jaoge, tardy labor. It will go on for hours and hours. More backache. The patient will complain of more backache, right? Premature bearing down, as I mentioned. Edema of anterior cervical rim because head is born more posteriorly and then pressing anteriorly, the remaining portion of the cervical anterior rim gets edematous. Early rupture of membranes happens most of the cases and that leads to excessive caput formation. So these are the labor characteristics of occipital posterior. Okay, as the labor is bound to be prolonged, first stage as well as second stage. Reasons are there. We have been learning this in our undergraduate days, postgraduate days. Patients, and what is important in management is patient and relatives should be fully counseled regarding the prolonged time, and mother also may get exhausted. So good counseling is required right from if you have diagnosed in late pregnancy, tell the patient your labor may be prolonged as compared to your other right friends or relatives labor, because now back is posterior. I always tell my patients that baby has to come out of the mother, baby has to separate from the mother. So if the mother's head is up, baby's head is down, baby will come out easily. That is what the cephalic presentation. Breech, it does not. Same, when the mother's back is posterior, the baby's back should be anterior. If the baby's back is also posterior, so it is a way of counseling. It's just a way of telling the patient to understand that there is something right difficult in my case. If pelvis is good, oxytocin should be used to augment uterine activity. Right? Pelvis is the most important. It corrects deflection and drives the head firmly on pelvic floor, leading to internal rotation. See, I will come to next slide. The uterine activity may be inherently weak, or it may be the result of occipitoposterior. It is a cause and effect relationship. So you should give oxytocin in the management if the labor is unduly prolonged. Okay, for that case, labor analgesia, epidural analgesia is best. It helps in many ways. It takes care of backache. Incoordinate uterine action also decreases. Manipulation and if required, cesarean can be done under same anesthesia. Pain relief allows for more waiting by the patient. Patient does not get tired or frustrated that so much pain, so many hours. So because there is no pain, she can wait whatever trial you want to give. So epidural analgesia, Madam Ranjana Madam, it was my dissertation topic in 1983, 40 years back, and my 5 residents have done this epidural in labor. Now there are changes, walking epidural and less sensory motor block. So epidural is just theoretical disadvantage of relaxing the pelvic floor leading to persistent occipitoposterior is not found by evidence. And also I told you my 5 students reached this. However, because something is happening, even if it is not right leading to persistent, but the labor is prolonged, somewhat instrumentation rate is increased because of prolonged second stage of labor. But the rotation does not is not a problem. Only thing pushing may be problem. Okay, now arrested, coming the real part. Deep transverse arrest, oblique arrest, occipitosacral arrest. We divide into 3, all these 3, and we learn this way. Most important is DTA is the commonest. Deep transverse arrest is the commonest type of arrest. The standard criteria are there, right? Second stage of labor, cervix must be fully dilated. Then and then you put it as a DTA. Sagittal systole is in transverse diameter. Maybe slightly, maybe you can say less than that. It's okay, not exactly transverse, but mostly transverse. Previously, half an hour was given for arrest. Now 1 hour is permitted. Station should be 0. Previously only 0. Now it is said even plus 1 station. If it is arrested, you can say it as a DTA. Good uterine contraction should be there because otherwise it leads to persistence of OP. And then arrest to occur means arrest to diagnose. You must have all the criteria. But what happens actually? We take decision early. We don't wait all things to happen, because we have a clinical experience and we think that this will not rotate, this will not rotate. Either you go for instrumental or you go for cesarean section. But theoretically, all this must be fitting in your case to put it as a deep transverse arrest. Okay, so this point is important. Do not diagnose arrested occipitoposterior before second stage of labor, right? 8-9 centimeter, no. And also, even in second stage, before 1 hour of second stage of labor, right? If arrest of labor occur in late first stage of labor, it is called failure of progress, non-progressive first stage of labor, and not arrested occipitoposterior. For that, you must reach the second stage of labor. Some heads rotate very late and sometimes at the outlet and not at the pelvic floor. Normally, pelvic floor is responsible for rotation, internal rotation, but some heads rotate late, that because of pelvic architecture. And if fetal heart sound is good and descent is happening, one can wait. Nowadays, again, many literature is coming that upper limit is not 2 hours or with epidural 3 hours. It is still 1 hour more is given by many guidelines that you can wait. Everything is good, mother, baby, then you can have successful vaginal delivery. suggest what are the bad omens. Once the patient comes, you deal with a patient of obstetric-posterior, what things tell you that it can lead to arrest. If it is a left occipital-posterior, more chances of arrest, because ROP is 5 times more common than LOP, and in spite of sigmoid colon there, head has preferred to stay in that position, it may stuck there. Then occipitosacral arrest from 7 to 9 o'clock, right? Postiofontanelli between that near, right? You can say 6 o'clock. 5 to 7 o'clock. 5 to 7 o'clock. Exactly in the midline. Sacroiliac joint say medially. If occiput is so posterior, it is less likely to rotate, mostly lead to arrest. When you do PV, antiofontanel easily felt on PV examination. It suggests moderate to severe deflection, and then the head will not rotate. So that is right the point that tells you it's a bad omen that mostly arrest will happen. And obviously early rupture of membranes, beginning of first stage of labor or middle of the first stage of labor, like a drains out, uterus retracted on the baby, baby wants to rotate, but the shoulder and the rest of the baby is trapped, head cannot rotate. So these are the bad omens where you think that you may end up in an arrested labor. So problem in occipital posterior is failure of internal rotation. It may be due to this standard 6 causes: abnormal pelvis, large head, weak uterine action. I mentioned previously that it may be a cause of the right occipital-posterior, or it may be also, it may lead to occipital-posterior effect, cause and effect relationship. Deflection of the head, right? That will not stimulate good uterine contraction, it will not dilate cervix more. Poor pelvic floor with or without epidural. Early rupture of membranes. Out of these, which you can tackle? See, this abnormal pelvis you cannot change. Large head, which you cannot decrease the size of the baby. Membranes are already ruptured. So what you can deal with is weak uterine action, deflection, manually correct or with good uterine action, and pelvic floor, poor pelvic floor, in a way is good if you want to plan instrumental delivery. It will not come in, soft tissue resistance will not come in your way, and you can be more successful in your right delivery, vaginal delivery. So arrested occipital-posterior. I put a big font size, cesarean section. What is happening nowadays is this only, but we have other options. Ventouse extraction. Ventouse you just apply, don't rotate like a forceps or manual rotation. Manual rotation, we were teaching and somewhat doing also manual, full and half hand under general anesthesia usually. But nowadays that is not there. You can do it with a 2-finger rotation. Some molding is there. If it is a transverse arrest, you can put your finger between that occipital, right, and parietal bone that is at posterior fontanelle. Because some molding, you have a grip, hinges, and then you can rotate it. So that 2-finger rotation I have tried many times and it is successful. At least for 60-90 degree you can rotate, not from full occipit to back posterior to anterior. Forceps rotation is not there. Rotational forceps, that is Killan, forceps Canjoni maneuver, double application is never done in world, but Killan is also done nowadays in UK and some of the other countries of the world, very few countries, but it's there. I am also doing, I have a video, I think if it plays, it is good, Killan, but it is not for now modern obstetrics, but I am also doing, I hardly done 20 Killans, total in 40 years, 20, you can count, 2 years, 1 Killan. Craniotomy only when the fetus is dead, because in that dead baby, you don't want to do cesarean section, and the head is very low. If you can catch with 2 Alice forceps, cut the scalp with scissors and pass a scissor inside. If you don't have craniotome, because craniotome is lying in the cupboard, may not be right available to you. So some brain matter comes out, head collapses, and delivery is so easy. Patient is ambulatory next day. If you do cesarean section of that, go a long trial, fetal death cases, you have a problem. You have a problem post-operatively, infection and everything. So craniotomy is not done nowadays, but only for such cases you can think of. So in occipital-posterior, average size baby, and to deliver face to pubis, if pelvic shape is good, gynecod anthropoid. It is face to pubis, pakka posterior, and then coming out. And size is good, and there are good uterine contraction. What is important is generous episiotomy is must, because bulky occiput is coming posteriorly, so it may cause tear. Now these lines are important. This I have learned from my experience. clue for diagnosis complete posterior position on PV is that one feels more bulk of the head posteriorly in the vagina. Normally we feel, right, that's inciput and occiput is anterior. Normally all vertex presentation. So retrospectively I could make out when the undiagnosed, when the baby delivered face came out, face to PV. Then I thought, why it is, we thought Sejal Suchal is in the midline and so it is rotated, but it was wrongly rotated and it face to PV it came out. And then I recollected while doing PV, I was having some, right, not a good feeling. So due to parietal bones more posterior placed, this is unusual feeling as compared to PV in routine occipito anterior position. So if you compare with your other patients, you can make out this, right? So that is a clue that when you feel something like large head, it is not large, it is occipito posterior. Okay, this is right, forceps delivery of face to PV is completely rotated. Under spinal anesthesia, I am doing it. Applied the blades. Usually, I use for these cases long forceps and not outlet forceps. So you just watch. I am not in a hurry. I wait for contraction to come. Pitocin drip also running, and obviously fundal pressure at the last moment also required. Right. Only one important point is not, or one thing is be slow, not in a panic or hurry. And second is you have to pull horizontally, not backwards. It will lead to extension of the face to pubis, means already haze is extended, face to pubis. So horizontal simple traction. You can see the face of the baby seen, eyes and nose and all things, right? So I'll put it for a minute, right? Cried is there, right? At that time we were doing early clamping and all instrumental delivery I used to clamp somewhat early, not a full 1 minute I wait. Same, right? Baby cries on table, pediatrician is happy. See the large, it was large molding and caput. Now the second slide. Now this is a vacuum. I manually rotated it. This is a Mitivac cup, very simple, small cup. Manually rotated it and then I applied. It was slightly incomplete rotation, but still vacuum you don't require to fully rotate. Vacuum does it on its own. So I'm checking after application that there is no tissue of vagina or cervix is never there because the second stage of labor. And then only I ask my assistant to create the pressure. See, only 3 pressing, the pressure is created. Mitivac cup, Mitivac, Kiwi Omni and Mitivac. This is Mitivac. Very simple, and sticks to head very firmly, nicely. Now again, I'm waiting, right? I'm sitting. Now somebody is giving fundal pressure. That right? Nurse is giving fundal pressure, right? During contraction only. Naturally, you have to do it during contraction. I put a very generous episiotomy, so sometimes I don't allow that, right? Guarding of perineum or support the perineum because I've already cut the adequately. You can see this, right? Slight because it does not stick. This much lateral movement is not required as such, but no hurry. And pull perpendicular to the cup. Otherwise, you have to support the anterior margin of the cup. See what's coming there, but I told that it is not required. Anterior margin of the cup with the fetal head. See, easily the head comes out, right? And you can see the caput on one side because it was not fully rotated. You can see it is not in the midline paramedian application, right? Now this third is not a proper video, madam. It is not for occipito-posterior, but just to emphasize that in vacuum, head rotates on its own. This is a cesarean section, vacuum at cesarean section. So normally I cut the uterine incision with scissors, initial part, and then extend it by fingers because laterally the vessel come. But at least half of the incision I cut routinely. Right. Now I am putting fingers and right stretching. So to make it an adequate incision. Laterally don't cut. Now cup is ready. Cup is applied. This is for floating head. That does not happen in occipito-posterior. But just at the last moment, I want you to observe the head rotates. See, vacuum is such a thing. Right. Now it is applied on the head. right? Again, no hurry, Liker was clear. Let the contraction come under sinal anesthesia. We are doing, right? Slight lateral. Again, you don't require to remove doyens. In a forceps at cesarean section, you require to remove doyens. Now see, it will, last moment, it will rotate, head will rotate. When it comes, I ask the pitocin to run. Just keep on watching. Keep on watching. Yes. I'm in no hurry. See, rotate over. That is the point. That vacuum, right, allows the rotation to happen. Allows the rotation to happen. Okay. So, baby is good. I'm not in a hurry to do this. Fine. Okay. Forceps. Applying forceps when you do want to do a forceps in a whatever rotated head by fingers or posterior, you can wait for some time in a second stage of labor. That allows good molding of the head to happen, right? If the FHs are good, you can do that. And even if you apply the blades in slightly unrotated head, it will not reach up to the face and it will not produce blade marks on the face because so much molding is there. It is there applied. The tip of the blade goes up to the just forehead only. So that is, I've learned that if there is nothing emergency, I will always wait, and then do the forceps when the head is also low and the blades do not go on the, because it is unrotated. Slightly, it may come like this. It should be like this, but it is not rotating. Then I always wait. Now, when you do PV, as I told you, sometimes people diagnose occipito-posterior as occipito-anterior because of caput molding and because, right, that does not allow you the proper analysis of Fontana's. So what you do is you must have the position clearly known when you do any forceps delivery. 3 fingers examination. You put a 3 fingers and there 2 fingers on 2 suture lines, and with middle finger you go on either side. On either side, if you feel a suture, then it is a right 4 sutures, so it is anterior fontanelle. If you don't feel on one side, then it is a posterior fontanelle. There is a false fontanelle here. Yes, this is a false fontanelle. It is there in 2 to 4% of cases. It resembles like anterior fontanelle. So don't get mistaken this. And the people say this is occipito anterior. No, it is occipito posterior. It is a posterior fontanelle. And one important point is lambdoid suture. Lambdoid suture is in a more curved surface. You trace the suture. If it curves, then it is a lambdoid suture. Sagittal suture and frontal suture and right coronal sutures are straight, nearly straight. So that helps you. If you have, I sometimes do this right before applying the blades because you don't apply the blades wrongly. Do PR. Because in caput molding, you think the head is so low. But if you do PR, you check that the whole of the sacrum is filled with the bony head and not only the caput is down. This is all for those who are doing forceps. People are not doing much forceps, but then it is very, very, very important, helpful. Okay, rotational forceps are not done for arrested occipito-posterior right? Okay, so that is there. But as I told you, I have a Killan. I told you, temptation to apply routine forceps on unrotated head should be avoided. Vacuum is always better. Vacuum is always less traumatic to the mother and always have auto rotation because it is from the axis. Any object can rotate around its axis. Blades are on the slide. You have to rotate the forceps. But vacuum, it is not required. I think I will pause there or something. Is Amit there?
Yes, sir.
I have to minimize this and I have to go for what should I do?
No, reshare, sir, reshare. There is a button reshare.
Okay. There is no stop share. करूं?
नहीं sir, वहाँ पर एक reshare button भी आता है. It has
reshare तो नहीं कर रहा है. Pause share, new share और escape करके जाऊं? Escape करूं कहीं? नहीं आता है. Stop share करके फिर से run करूं?
आप stop share कर लीजिए.
Okay, then आता है अभी कुछ? हेलो?
अभी नहीं सर, कुछ भी नहीं आ रहा.
नहीं आ रहा है. Okay. Share screen करूं? Okay. Okay, देखो अभी आता है कुछ आया?
Yes, sir.
Now this is Kilan. Already the two blades are applied, right? Kilan forceps. I'm rotating. It was anterior and posterior blade. I think I should run from here. Okay. Now, first, this is the blades. You decide on the ROT or LOT. It was a ROT case, right? Spinal anesthesia given. Anterior blade is to be introduced first. Episiotomy already given. There was one bleeder, so one artery forceps is applied. Direct method I use, so I am applying the blades directly. Right? Okay. Fine, it is properly in. Always when you apply the blades, go pull in the hollow, the pelvis. When posterior blade is there, it is in the hollow of sacrum, but this anterior blade, now the artery is removed because I have to introduce the posterior blade, which is directly posterior. It is 2 minutes video only. So now I am introducing the posterior blades, right? I have all videos, forceps and vacuum videos, at vaginal, at cesarean, 10 videos, different, breech and everything. Here I have put only 4. Sliding lock. In a Kilan, there is a sliding lock to correct the asynclitism. So now I am rotating. 3 force you don't apply. These are compression force, traction force, and rotational force. When there is no pain, you rotate. And when there is a pain, you pull. So I am waiting because contraction came, I am waiting. Now I am relaxed, so I am rotating. Now rotating. Now the anterior and posterior blades will become right and left blade. And then delivery will happen. Pull only when contraction comes. Now final rotation has happened. Blades are clearly seen right and left. And good episiotomy support is not given and right. So that is again under anesthesia. I am not worried, right? At that time, nowadays pediatrician don't allow this. Cord is there, so cord is loose, so I'm putting it back rather than removing. That is okay. Okay, I think I should stop share this. If one is not trained and confident in instrumental delivery, naturally cesarean section is better. However, there are risks or tears due to difficulty in delivering deeply engaged head, as we all know, leading to PPH. So 2 slides only for this point. Deeply engaged head in pelvis. Push method, push from below. 2 things. Insert full hand inside, not 2 finger push or not 4 fingers. Full hand inside. It gives you more depth when you are pushing from below. It gives you more strength also, full hand. Be ready after anesthesia and not in emergency measure that after baby head is not delivering by the operating surgeon, then you remove the towels and pass the hands in the vagina. This is to be anticipated and done from the beginning, right? At least hand at the vulva, and then as soon as before he puts the incision on the uterus, you push the head. So that is the proper way, push from below. But what is important is pull method. Modified Patwardhan. I met Sir Vasant Patwardhan. His father, B. Patwardhan, devised this technique. There was lots of confusion. So I went personally to Mumbai, his office, consulting room, and because he was colleague of my teacher, and that's why I discussed with him. He said in our times, occipito-anterior, we were doing less cesarean section. Cesarean section was risky 50 years back, complication of bleeding and infection. So we were doing more trial to occipito-anterior, and then getting jammed in a contracted pelvis. So I devised a method of shoulder in back anterior, shoulder delivery, and then Patwardhan. But nowadays we take the decision for any non-progressive first stage of labor early. We don't give that much trial in occipito-anterior also. Except posterior, thinking that it may rotate, 90% will rotate, we give trial, and then we are in a soup. So modified Patwardhan, when the occipital posterior get arrested, the limbs are anterior. So you pass the hands up, you have to go really deep up. catch the leg, reach up to the fundus, go till fundus, and then catch a leg and deliver as breech. Right? When I teach to my students, some of them they are very happy. Sir, it is very nice technique, very good thing. And some of them they tell, sir, it is difficult to pass hand. What they are doing, because they are doing during contraction. Wait for 30 seconds. When contraction passes off, pass a hand and go deep. And one clue I will tell you, that if some limb comes very easily out, it is always a upper limb. Hands have a very free movement. Fetus hand also. Legs are our legs are having less movement. So if you have difficulty in catching the limb and pulling it out, it is always a lower limb. This is a clue. See, we are not like Allu Arjun or Prabhu Deva, then our legs will also dance, right? So that is not there. So because limbs, upper limb is very freely mobile, it comes easily, then it is a wrong thing. You never shake hands intra-uterine. You never pull a leg extra-uterine. बाहर किसी का पग मत खींचो, अंदर किसी का हाथ मत खींचो. Shake hands मत करो, बच्चा will cause you a problem. Okay. It is very rewarding and not difficult. Not difficult. Try practicing it. And also evidence supports pull method. Right? You must have come across in these various conferences also. So this is modified Parpardun, right? Very important. So now I'm at the end of my presentation. It is a responsibility of senior obstetrician teachers like us to prevent this art from dying. Otherwise, these instruments will soon vanish from obstetricians' armament. Right? It will be there in the graveyard. It is not good. At least in say 5% of cases, it has a very definite role, instrumental delivery. It is paradoxical that you readily cut an abdomen of a young patient when she is pregnant. Right? But when the same patient becomes 35, 40, and for gynec problems, he comes to you, you don't want to give scar on the uterus. You want to do NDVH. And 25 years, you cut the abdomen. Cesarean section. Okay. Then everything revolves around the skill, obstetrical skill. So what is skill? Skill is neither a gift nor a luck, not an inherited virtue. It does not pass on generation to generation. Not parallel with IQ. I have seen genius, not good surgeons. Genius in theory, not good surgeons. Never acquired by Eklavya approach. Ranjana madam का आपको मंजू मैडम का फोटो रख दिया तो आएगा, ऐसा नहीं है. Okay, skill never comes automatically. Skill is acquired by proper training under a good teacher and lots of practice. Right? My teacher is there today. Incidentally, is no more. He died 2 years back, 93, and today is the death anniversary. I am going for prayer also there. Right? Because presentation was booked there. Where experience has no substitute. Experience has no substitutes. This is a comedy pic of my residents, right? On mannequin. They were telling me, sir, आप WhatsApp करते हैं तो इतना difficult नहीं होता है. हम तो करते हैं तो ऐसे होता है, या तो patient नीचे आ जाता है, या तो हमको खींचना पड़ता है. So this is, they're struggling. But then I tell them that is, I am more the double of your age. That experience matters. Experience matters. So, ladies and gentlemen, every morning, in Africa jungle, a deer wakes up. You know this. It knows it must run faster than the fastest lion of that jungle. It will be killed. In the same African jungle, every morning a lion wakes up. It knows it must run faster than the slowest deer or it will starve to death. So it does not matter if you are a lion or a deer. What is important is when the sun comes up, you would better be running. Who runs the whole life is called an obstetrician. Thank you very much, ladies and gentlemen. God bless.
That was really excellent, Dr. Haresh.
Thank you, madam. Thank you.
But Doctor, for free head and all, I'm like routinely taking it out with the breech. Just, yes. I mean, by doing a cesarean, just put the hand inside, catch the breech and do a breech extraction, because that I find is the easiest. Whether it is deeply obstructed head, whether it is a free head, In all these circumstances,
Okay.
I go in
Okay,
for,
all cases, very good.
in all
This is-
cases, sir, except if it is, of course, coming very easily with the hand, I'll
it's
take
okay.
it out. Otherwise, I don't use any instrumentation. I always prefer a breech extraction. I just go
Very
right
good.
inside, take the
In-
breech and take it out.
Very nice point. Vaginal delivery, Potter from Buffalo, he used to convert vertex into breech and delivering vaginally as a breech. Potter from Buffalo. He has
Okay.
produced a paper, vaginal delivery.
No, I'm doing it in cesareans.
cesarean section. That is a nice, I will try it next time.
Sir, it's very easy.
Very
Just
easy.
put hand inside, catch the breech, and it comes out so easily.
Arre wah, great.
I never do Patvardhan's technique.
Yes,
In my
yes.
life also, I've never used an instrument in cesarean.
Yeah,
I'll just take
never.
out with the breech.
Yes, yes.
Never in
Madam,
my
Manju,
life
madam.
I've used a forceps or a vactus or anything.
Yeah.
Yes,
Just
yes.
bring the leg and deliver the baby. That's
Yes.
the easy.
That's the
And I
easiest
must
way.
congratulate you, Dr. Haresh, for such interesting.
Excellent.
Explained
Thank you, madam.
everything
Thank
so
you.
excellently. But the only thing I would like to add a little here, because one should always decide that the delivery can be done vaginally, because most of the cases it may be in right pelvis. So one has to assess whether the
Yes.
lower part of the pelvis, there's no CPT existing down.
Yes.
And the other thing is, I think the cup of the vacuum should be applied as near to the posterior fontanelle
Yes.
rather than anywhere
Make it
else.
flat.
Because, yeah, these are the
Excellent.
two things that one should take care of.
Correct.
Thank you very much, Dr. Haresh.
Thank you.
Sir,
madam.
very lucid,
Very,
very
very
lucid presentation. Very lucid. You
Thank you,
keep us
You
all
have always
gripped.
been like that.
Thank you so much, sir. So many interesting
Thank
and
you.
very, very practical points you told us. Thank you so
Yes,
much.
thank you, Madam Chitra.
Thank you, sir, for this wonderful, wonderful talk. Listening to you is always a treat. Thank you so much, sir.
Thank you, Dr. Amita.
Moving
And
towards,
we'll be looking forward to your All India survey findings after my talk.
Yes, yes.
Yes.
After your talk. After your
Yeah.
talk.
Yeah.
Okay.
Sir Sahoo sir is there. Sir, you want to say something?
No, actually, listening to this beautiful talk, totally amazing, I can say. Practical demonstration
Yes.
through ventus and forceps. That to Killand. Killand is actually history for us because we have
I've
seen
never
our,
applied.
Yes,
we
yes.
have seen our teachers applying it.
Yeah,
But,
Huh?
yeah. But now it is in the museum, so that is the place of Killand. So you have to keep it.
Obstetrical museum.
Right, but you will be surprised. One of my students is in their UK and they do it every week. There is at least one Killand every week.
Okay. Okay.
He told me that's why. Yeah.
So as you sir
But that
said,
pelvis may be right. Western females may be adequate, not causing much trauma by instrumental delivery.
So you
Maybe.
are also doing, na, Dr. Haresh?
Yeah.
You also
Yes.
doing?
No, but hardly I told you not once in 2 years.
so Dr. Haresh, what you said actually, it is not difficult to apply any instrument and do any procedure of surgery or skill or maneuver. It depends upon three things, as you said: practice, practice, and
And
practice.
practice.
Yes.
So that's the only thing actually we need it, because now we are impatient to do something we are afraid of because of litigation and because we are doing a defensive practice. And more so, we found that the procedure of teaching with in the transition phase with the teachers, we are killing the tricks of obstetrics. That
Yes.
we can. Yes. Thank you, sir.
So moving towards the second session, and very interesting and controversial topic, fundal pressure to give or not to give. And to speak on this, we have our president, Dr. Khanna ma'am, and to chair the session, we have with us Dr. Rita Mittal. Please, Dr. Rita Mittal is an infertility specialist and laparoscopist. She had been president Kanpur FOGSI. She had been organizing chairperson of pre-Congress workshop on critical care of obstetrics and newborn. And she has also been president IMA Kanpur. Welcome, ma'am. Our next chairperson is Dr. Kanchan Sharma. Dr. Kanchan Sharma is Secretary of Kanpur Obstetrics and Gynecological Society, President IHRF Kanpur, ART Specialist, Laparoscopist and Colposcopist. She's recipient of various awards and she has organized many national and international conferences. With this, I will request Dr. Kanchan Sharma to please introduce our speaker, Dr. Khanna ma'am.
Yeah. First of all, I want to thank the organizers, Dr. Khanna ma'am and Dr. Amita, for such a wonderful academic feast. Dr. Ranjana Khanna, as we know, is the leader of the leaders. Actually, she is a very good teacher too. I have been with her. She is have very good concept of all the things. She was the national vice president of FOGSI in 2017 and founder president Prayagraj chapter of ISOPARB in 21 to 23. ICOG Gynae council member from 2021 to 23 and president AOGS 2013 to 16. She was at the various posts and organized different national conferences. We have seen so many good conferences organized by her very successfully and wonderfully. We still remember all the conferences. She was always remains the faculty at the various national and international conferences and achiever of many national awards like FOGSI Dhira Award, FOGSI Dr. D.K. Tank Reproductive Healthcare Promotion Award, and FOGSI Smriti Mylan Award, Save the Girl Child. And she was felicitated by many committee, even by the Safe Motherhood Committee, AICOG, and by AICOG 2016. She has authored many articles and chapters in various book and journal. उनके बारे में कुछ भी कहना सूरज को दिया दिखाने के समान है. Very lovely nature. Madam, the floor is yours.
Thank you so much, Kanchan. My topic today is very interesting and it has actually come to life because of Dr. Haresh Doshi's survey that he's doing. All India survey on fundal pressure to give or not to give. So, fundal pressure was first described in medical text in 1870. It has remained an accepted obstetric practice and is currently used in some fashion in approximately 80% of all vaginal deliveries. The belief is that applying gentle assisted pushing, known as gap, accelerates the second stage of labor by helping the mother bear down and move the baby into the birth canal for the final stage of delivery. Fundal pressure during the second stage of labor involves application of manual pressure to the uppermost part of the uterus directed towards the birth canal in an attempt to assist spontaneous birthing and avoid prolonged second stage of labor and need for operative birth. This is also known as Christella maneuver, named after Samuel Christella, who first talked about it. Fundal pressure, though widely used, is however not much reported. Though there are strong opinions in favor of and against the usage of fundal pressure, there is limited evidence regarding its maternal and neonatal benefits and harms. Now, what are the methods of giving fundal pressure? First is manually, with the caregiver's forearms, elbows, and/or palms pressed on the uterine fundus at an angle of 30 to 45 degrees to the maternal spine in the direction of the maternal pelvis. It is given during contractions. It should be gentle, firm, and steady. There's also an inflatable belt known as labor assister, which inflates to apply synchronized, constant fundal pressure during contractions. So, when to apply? To shorten the second stage of labor. During cesarean, for an assistant applies fundal pressure to help in taking out the baby through the uterine incision. Third stage, to hasten the expulsion of the placenta. Now, what are the indications? Prolonged second stage, fetal distress, failure to progress, maternal exhaustion, or medical conditions where prolonged pushing may be dangerous for the mother. So imagine the scenario where the head is in second stage of labor, the labor is in second stage, the head is at the introitus, but the mother becomes very exhausted, fetal heart is slowing down, and we don't have any option, and the patient is unable to bear down. So that one gentle push will help in taking the baby out. Applying fundal pressure is often used to assist spontaneous vaginal birth. This shortens the second stage and reduces the need for instrumental birth and or cesarean. It is particularly relevant in low resource settings where these facilities are not available of in operative delivery or of cesarean or instrumental delivery. Now the prevalence. The practice of fundal pressure varies greatly between countries. In many low and middle income countries, the maneuver appears to be a routine practice during vaginal births. In most Western countries, however, it is regarded as an obsolete procedure, maybe because of intense medico-legal climate in these countries. And because of the medico-legal problems, this may also contribute to underreporting. They do it in hospitals, but the hospitals don't want to report it's being done. A systematic review and meta-analysis in 2021 from 76 studies, including approximately 9 lakh women across 22 countries, showed a prevalence of fundal pressure ranging from 0.6 to 69.2%, average being 23.2%. There were significant differences in prevalence between country income level. Prevalence was highest in the lower to middle income countries and highest if the patients were reported and that was being taken into consideration vis-a-vis the hospital reports, because hospitals always tended to underquote. What are the adverse events which could be associated with fundal pressure? Perineal lacerations, most are superficial tears healing on their own. Fundal pressure significantly, however, increases the risk of 3rd and 4th degree perineal tears. Uterine rupture could be one of the most dangerous complications. Uterine inversion, again, it is rare, but it can be fatal. It can be fatal, and it can occur if the fundal pressure is being given in between the uterine contractions. PPH, severe maternal morbidity, including rib fracture and or death. Now, a word of caution. This is very important, that fundal pressure is often used wrongly in combination with other obstetrical techniques in shoulder dystocia. We must remember in shoulder dystocia, what is needed to help is the suprapubic pressure and not fundal pressure. If we give fundal pressure, then the baby's shoulder gets further impacted against the maternal pelvis. So please, if you are even suspicious of shoulder dystocia, do not attempt to give fundal pressure, because that is going to worsen the situation and it can fracture the baby's pelvic bone and may cause permanent birth injury, Obst palsy. So long-term consequences could also be there, like fecal incontinence, urinary incontinence, dyspareunia. In the baby, there could be, because of the neonatal trauma, there could be fractures, hematomas, neonatal encephalopathy. Now, Japanese have come up with guidelines for fundal pressure in 2017. These guidelines are, number one, that only obstetricians can perform fundal pressure. Operators should stand by the side of the patient. Continuous CTG monitoring should be done. Should only be done in the second stage of labor, obviously. Expulsive force should be increased gradually. The number of trials should be equal to or less than 5. And the total duration of trials should be equal to or less than 20 minutes. Don't keep on and on and on trying. So, what are the controversies which are associated with fundal pressure? WHO and other bodies specifically refute the use of fundal pressure. They say it is not beneficial and could be potentially harmful to the women. Despite this, the use of fundal pressure in second stage of labor is still widespread. Efforts to prevent this potentially unnecessary and harmful practice is therefore needed. 2017 Cochrane review found no difference in mode of birth outcomes or duration of second stage of labor in women with manual fundal pressure. However, more patients had cervical tears rather than those who were not given fundal pressure. Use of fundal pressure may result in reduced patient satisfaction with labor and birth experience because of patients reporting discomfort, and nowadays there is a lot of stress on respectful maternity care. So it is very important that the patient should be satisfied with her labor experience. So role of fundal pressure. Okay, applying pressure on the uterine fundus extra-abdominally. Now we are talking about the role of fundal pressure during cesarean. So applying pressure on the uterine fundus extra-abdominally to hasten the delivery of the baby is generally considered harmless, partly because it is applied only for a brief time, approximately 3 seconds. However, fundal pressure will inadvertently compress the inferior vena cava or the aorta. In a study in 2006, mean systolic aortic blood flow time, cardiac output, heart rate, and BP all decreased significantly while the pressure was being applied. But since this is for a very brief duration, there is no evidence of any harm to the baby or the mother. Now, when we talk about fundal pressure in the third stage of labor, Creed's maneuver, we all are familiar with this. It is said to help in separation of the placenta after delivery. This is done by placing the hand on the fundus, squeezing the fundus between fingers after rubbing up a contraction. It is done to separate the placenta and expel it through the introitus. Now, 2 basic interventions help to deliver the placenta as part of active management of third stage of labor. We all know this. Number 1 is fundal pressure, and number 2 is controlled cord traction on the umbilical cord. Fundal pressure may interrupt the process of placental detachment, cause pain, hemorrhage, or uterine inversion, especially if it is given in between the contractions when the uterus is flaccid. The obstetric clinical practice on this issue is not standardized. So there are a lot of studies on fundal pressure. Asti Parveen et al. In 2020 found that fundal pressure maneuvers increased maternal and neonatal complication rates. So healthcare providers should consider patient circumstances before applying these maneuvers. Hoffmeyer, G. Justice et al. In Cochrane database of systematic reviews in 2017 said that there was insufficient evidence to draw conclusions on the benefits versus drawbacks of fundal pressure. Hence, further research is needed to see if fundal pressure actually harms the fetus. Pinar Sembra et al. In 2018 found that fundal pressure did not negatively impact maternal satisfaction or maternal and infant health. Takmas Taha et al. In 2020 found that fundal pressure was associated with anterior vaginal wall prolapse and levator ani injuries. And Yusuf A. et al. In 2019 studied the association between the Christella maneuver and levator ani muscle avulsion and found increased prevalence of levator ani muscle injuries in women who underwent Christella maneuver. Now, fundal pressures around the world. What is the situation? US hospitals 2005 to 2006 saw a huge drop from 84% to 5.9%, but 17% of the mothers reported use of fundal pressure during labor. So that means that the hospitals were not giving the correct report because the minimum was 5.9, but 17% mothers were reporting the usage. Fundal pressure is commoner in Italy, Bulgaria, Brazil, Turkey, Japan, and India. Also reportedly used in Germany and Honduras. Inflatable bells for fundal pressure used in Korea and Italy. In Egypt, the use is 24%, in Brazil, 37%. But in UK, applying fundal pressure is prohibited. So to sum up, WHO and several other national obstetric societies specifically recommend against usage of fundal pressure. However, despite these recommendations, there are reports of routine use of fundal pressure during vaginal birth. The prevalence of its use, however, has not been determined internationally. Why? Because of underreporting. They don't report this. The Japanese Societies of Obst and Gynae advocates the use of fundal pressure alone or in addition to vacuum or forceps applications, as Dr. Haresh was telling us, when it is necessary to support inadequate maternal efforts or an arrest of the fetal presenting part in the advanced second stage. So does fundal pressure actually help? Though fundal pressure is still a well-accepted obstetrical practice, recently it has become controversial. Many obstetricians strongly recommend the routine use of fundal pressure. Others have condemned the practice entirely. A number of research studies have been done to evaluate whether fundal pressure actually helps to accelerate the second stage of labor or not, but no study has been able to establish any clear benefit. The general consensus is that we simply do not know. Thank you. And now I will request Dr. Haresh Doshi to tell us more about it.
No, nice, madam. It was a nice presentation. I think you traveled the whole world, right? Everywhere the people are same. People are doing it and not accepting it.
And not accepting.
Because if I am doing instrumental delivery a lot, but because my students did not want that, they are not practicing that, then it came to my mind, then what is the option? Cesarean section is not the option. It is a problem, right? Increased cesarean section rate. That's why fundal pressure, we have started in medical college also, in my private also, 80% cases we use. And that's why in the survey.
But we don't want to report. So when your survey came, I readily wrote that yes, we use it.
Yes, you are right. Prospective study we are planning, and then it will be published, I think. Okay. I think there are 8 slides, 8 questions were there. You must have answered. And let me put it that way. Right. PowerPoint.
And the chairperson would like to give some comments, Dr. Rita Mittal.
Hello, Ranjana.
Hello.
It's really nice to be chairing your session. तुम्हारा साथ तो हमारा friendship है 56 years, school friends. So you have covered it very nicely, very clear and crisp on the controversial topic. But we have to beware in the second stage of labor in the labor room when we are in great panic, head is not coming down. So we just ask any Aya or cleaner who's standing there to give fundal pressure. They have no experience and sometimes they are pressing the thorax and not the fundus. So we have to be very careful who is giving the fundal pressure. And secondly, it has not been documented. Everyone is doing it, but it has not been documented. So we don't have real evidence on how important is the fundal pressure. So nicely covered. Very nice.
Sir, now your opinions, your survey.
First question was, do you use fundal pressure, right, during delivery? 81%, right, said, right, sometimes. 13% says always. Only 5% said no. So only 5%. 81 sometimes, 13 always. Second, who gives fundal pressure? Right? Healthcare worker by 56%, doctor by 39%, 5% are not doing. That's why they did not answer. But this is healthcare worker, any sister or labor room staff.
Yes.
That was the second question. In what percentage of it is successful in your experience, those who are giving it, right? It was by 40% said it is successful, 31 says yes, partly successful. I'm sorry, I go back. And 22 points say it is less successful. So so 40 and 37, 77.2 it is says successful. At what station you give, right? Mostly at crowning, 56 points. This is +3 and this is +2. So very few people give early, but otherwise people give at +3 station and at crowning, below +3 station. Okay. Do you use fundal pressure during instrumental delivery? Yes. So, right, sometimes and always 10% are not doing instrumental delivery. That's why they said, no, we will not, right, use fundal pressure because they are not doing instrumental delivery as such. So that is again goes to 5 to 10% are negative, otherwise all positive. Do you give episiotomy before fundal pressure? Yes, 68 says yes, first episiotomy, then if required fundal pressure. 24% says okay, but 8% no. So that is right, sometimes, always, right, and no. So that was the 6th question. And what are the complications? So perineal tear, that is half of the respondents said that some perineal tear occurs. Only 5% say anal sphincter injury. No problem, says 44.6%. If you are controlled pressure, there is no problem. That is by 44.6%. And for what number of patients, right, number of pains you will give. So, right, 51 says, right, 3 to 4. I am not able to read it in my slide, but you will have, right, so it's 24.6%, 20. So, as one study you mentioned, Ranjana madam, that say up to 5, it is Japanese guidelines says up to 5 it is permitted.
Up to
but
5.
normally we don't go to more than beyond 3, right? Then we stop the procedure and think of something, instrumental delivery or going for, if required, cesarean section. But WHO has refuted, but in the last line of that article I read, WHO, that they said that with stringent protocol, the general assisted pressure, that is fundal pressure, should be studied and evaluated. As on now, the evidence says they refuted WHO, but they are also last line they have mentioned that control study should be done of gentle pressure so as to make it evidence based. Okay, madam. So that is last.
Can I say something? Can I say something?
Yeah,
Yes,
of
madam.
course.
Okay. So the one thing is that it should be individualized. It should not. Do you think it should be given to every patient? No, I don't think.
No.
It has an indication if you want to do it. Okay. The other thing, the injuries that have occurred is not because of the fundal pressure. Because when the delivery is taking, actually you are it comes out suddenly. So the bigger diameters are coming by the injury occurs. It is not because of fundal pressure. And the other thing is, if we want to do it more scientifically, I think we should make out some sort of a grading that how much pressure is to be applied. Whether we can calculate it by the angstrom or the weight measures or whatever it is, because sometimes it will be given very forcefully. Some people give it very lightly. So there has to be a measure by which we can say that this is the amount of pressure that should be given, not beyond it. So that is, there are certain things which one should consider before giving fundal pressure. If you are making the patient uncomfortable by your pressure, I think you should reduce the pressure.
Yes.
That's what I say. And,
I discussed with FIGO president, past president Arul Kumaran. He said that in USA they started, but they could not control, they calibrated the pressure. That's why they stopped it. And as you mentioned, it came down to 69 to 5%, and then 17% mothers reported. It is still there, at least. But that happened in USA.
Dr. Kishore Rajurkar is saying that fundal pressure is antagonistic to the perineal support. He's a professor in Delhi.
What he wants to convey means antagonist to?
He's saying that fundal pressure is antagonistic to the perineal support.
No.
That is there.
So
But
that
we have to think of not doing instrumental delivery, doing lot of cesarean section with subsequent complication, fetal distress, prolonged second stage, mother is in pain. So you have to consider all factors.
Of course, and then we have already, we have basically given the episiotomy. We have made room.
Yeah, you have given you have cut the perineum.
Not
So
giving the
that is
pressure.
It is
basically that you do not allow the premature extension of the presenting part.
Yes.
So it is not that you are pushing from below and the other person is pushing from down. No. Perineal pressure, perineal support is only said you do not allow the premature extension of the hair.
Of course.
Yes, madam.
They are not.
Yes.
Amita, take up the questions.
Sir, there's a question for you by Dr. Dipain Parekh. what to do when there is decrease in pain intensity during the second stage of labor, how to proceed when it happens with the fetal distress.
Miss, you have augmented by oxytocin already or not? If you are not augmented, augment it by oxytocin, increase the trip rate, uterus will respond. If all the right receptors are not saturated, increase in contraction will happen. Then fetal distress is there, give oxygen to the mother, give simple drips. I mean, if oxytocin drip is there, and then go for instrumental delivery. Weak contraction is there, as you said, weak contraction is the labor is getting prolonged, fetal distress is there. So to deal with everything, increase the drip, give oxygen, and go for instrumental delivery if prerequisites are fulfilled.
So fundal pressure, actually, I don't think it is controversial. Rather, it is a usual procedure. Everybody does it and brand it as controversial.
Yes, you are right. You are right, sir.
Sir, when in the rural areas, in my young age, when we were doing postgraduate or first posting in 70s, early 76, 79, so we have collected the history that to expedite the process of labor, even women were standing and dancing on the abdomen to give fundal pressure. So to that extent, it is the history. And the second thing is, it is advised to give gentle pressure. How gentle is
exactly? There is no
parameter.
You can't calibrate it.
Parameter at all.
And one incident I can cite during my post-graduation, my professor asked who will give the fundal pressure. And I was rejected because my weight was 52 kg at that time. So I was not selected to give the fundal pressure. So another scientific thing is that if the fetus is compromised and placenta is fundal or in the upper segment, don't give fundal pressure. Because by giving pressure, we are again reducing the blood supply to the fetus. So therefore, that is one scientific reason I have experienced that it should not be given.
Only thing the nature's way is from push from above. Where uterus contracts from above, mother pushes from above. A little aid by you is not harmful.
It's not harmful. Little help.
It is
But
from
then,
above only.
sir, I feel you should be careful in excluding shoulder dystocia.
Actually, when you give
that
fundal
is the
pressure,
only problem
lady
that could occur.
Also gives pressure. She also gives pressure because she wants to avoid. So she gives the pressure along with you.
And as Manju madam told, we have to calibrate. We have to make some like grading.
By which we can calibrate.
Yes, madam.
So Monica Allah, any technique required or helpful to deliver the head to prevent extension of perineal injury during fundal pressure?
As Manju madam told, you have to keep the flexion. That is there. Otherwise, simple, same as vaginal delivery in other cases. You have to sudden premature extension, you have to prevent, but don't give it too much that does not come out. Don't give it so much because as such you are pushing, helping, pushing, and now you are stopping. So that should not happen.
And another by Dr. Dipen Parekh again, fundal pressure, how to apply intermittent with thirst or continuously?
No, it is intermittent. It is during contraction only.
During contractions, continuous.
Yeah, madam. Yes.
Dr. Shashikala Sahoo wants to say something.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Good evening to all.
Good evening.
Doshi sir, good evening. Very nice.
Good evening, madam.
As always. From Ahmedabad.
Yes.
Yeah, please say what you have to.
Just tell about fundal pressure.
Yes.
Here at private hospital, most of the time it is given by the pediatrician who is attending the labor.
Yes, or anesthetist.
Yes.
Or the anesthetist. But
or the
most of the time,
anesthetist.
because 100% pediatrician is present at the time of second stage of labor or at the time of delivery at private hospital.
Like anesthetist is at cesarean section, pediatrician at vaginal delivery.
Yes. Second, sir, I just wanted to share one experience. one
Yes.
patient from a village area. She
Yes.
was giving by herself the fundal pressure.
Oh,
And she
great.
was not giving in the center, I tell you, sir.
Yes.
She was giving from one of the angle of the fundus.
Acha.
Okay.
And she was a fourth para. She told me, I can feel where the baby's butt is there.
Yes.
Seeing the baby's butt. And I
I
tell you, that
think she
was
must
so
be very
effective.
intelligent.
And baby was of 3.8 kilo.
And she
Oh,
took it out.
Yes, she took it out. We
Manju,
have not
wo
given
to
fundal pressure. She herself has given.
very intelligent. She has taken.
mother is the best
After
obstetrician.
that, sir, the story doesn't end here. After that, sir, I have also started palpating where the fundus, I mean, it is in the center, but or whether it's little bit left or right. And I told the pediatrician, you push from here. Let us see what happens. And believe me,
Yes.
sir, that is helpful.
Oh, you were
Even 10%, it is
negotiating the longitudinal axis of the baby and
Yes.
the latitudinal
Yes, that
axis.
is the simple obstetrics.
So this is going to be beneficial.
Yeah, of course,
Yes,
it will be
Dr.
beneficial.
But yes.
Thank you, Ranjana ma'am. Thank you, Doshi sir, for your survey. And thank
Thank
you
you.
all, chairperson and everybody who are in this interesting discussion. And moving towards the third session, I would request
Kanchan
my,
रह गई है, Amita, Kanchan.
Dr. Kanchan, you want to say something?
There are a lot of comments in the chat box, no?
The comments are it should not be done by untrained staff. Sometimes scary scenes encountered. Complete procedures reducing fundal pressure. Dr. Rita Mittal has said. Dr. Kishore Rajukar, most of the time perineal pressure is given at drowning when we give perineal support to prevent sudden delivery of head. I don't give it and have found it harmful as the method is not standardized.
I think it depends on the choice of the case. And it is individualized, and when you actually need it,
Yes.
if
Then
the
do it
head
now.
is already crowning and just that little push is needed because the mother is totally exhausted, that is the time when we can easily give, and we have ruled out shoulder dystocia, so we can give it.
Request Dr. Uma to kindly introduce Dr. Uma, Secretary of Allahabad Obstetrics and Gynecological Society, to kindly introduce the chairperson for the session and take this session forward.
Good evening, everyone. Thank you, Ranjana ma'am, Amita, to including me in this webinar. Now we are moving to our third session, that is postnatal urinary retention and SUI, new aspects. After an enlightening talk of fundal pressure, Dr. Haresh Doshi, it's a very good talk, and we are doing that rotation and everything. I am using forceps, sir.
Yes, good.
I am using forceps. I am from BHU, so I am using forceps.
You are
Great. Nice
using
to hear.
keelant. Are you using keelant forceps?
No, ma'am.
So फिर outlet forceps, so I am also using.
Outlets तो सभी use करते हैं.
हाँ, keelant forceps में कलाकारी है, mid cavity, rotational forceps.
Yeah.
Now we are, I am introducing the chairperson of this session are Dr. Usha Goenka. She is President, Kanpur Obst and Gynae Society. She is a trained IVF and infertility of Institute of Reproductive Medicine from Kolkata by Dr. B. N. Chakravarti. She is postgraduate certificate in hospital management, past distance learning program in medical law, ethics, attend World Conference Breast Pathology, BreastCon 2017. She is life member of many organizations like FOGSI, IMA, IMS, ISPAT, ISOPARB Kanpur. She is Vice President COGS 2019 to 2021. Currently she is President. She has been positioned on Secretary COGS from 2012 to 2014. She is Executive COGS for many years. She is a very good social worker and life member of many social organizations. Her special interest in preactive obs and gynae, medico-legal ethics, and adolescent gynecology, social service, male infertility and breast issues. Another chairperson is Dr. Amita Varma. She is MBBS MS Obst in Gynae, GSPM Medical College, Kanpur. She is founder secretary Faizabad Obst in Gynae Society, Ayodhya 2019 till now. She is a consultant in Deva Memorial Hospital, Institute of Advanced Endoscopy, Laparoscopy, Hysteroscopy Training, Beams, Okla Endoscopy Center. She is participated in many as faculty in national and state conference, medical and social. She is passionate about women health and rights. She organized rallies about cancer awareness, gender sensitization, conducted a school program about sex education, menstrual hygiene. Miss. She is life member of IMA FOGSI ISAR IHRF. I am requesting Dr. Smita Varma, please introduce our speaker, Dr. Kiran Pandey, ma'am.
Good evening, everybody. I bring greetings from Ayodhya, the birthplace of Lord Rama, and I'm very pleased to introduce Dr. Kiran Pandey. She is the ex-HOD and Professor Obs and Gynae, GSVM Medical College. She is the ICOG Governing Council Member 2021-23, Chairperson IMA, Vice President UPCOG, Vice President UPAGOI, Past President COGS IMA. She has many awards at national, state, and district levels. She has actively participated in all activities of FOGSI from 1988. She has more than 150 research articles. And on a personal note, I want to say that as I am from GSVM, when I joined as a junior resident, she was my professor, she was the junior most, and I was her first resident. So I'm very happy that I'm chairing this session for my teacher. So Dr. Kiran Pandey, the stage is all yours. I hope you are connected now. And after doing some antenatal maneuvers, we are now in the postnatal incontinence and SUI issues, which are, I think, equally important. So let us have a good learning session.
Thank you, Sumita. Dr. Amita, have you got my presentation?
Yes, ma'am. Amit is sharing.
Yeah. So thank you so much. Actually, I could connect to the desktop, which doesn't have a camera. I realized it so late. There were so many minor confusions. Anyway, thank you, Dr. Ranjana. Are you able to hear me all very well?
Yes, of course.
Right. So,
Of course.
Nice words. Amita taking so much pains. And Dr. Harish Doshi, I just saw. I wanted to even attend all the things, but because of our conference, we were so busy. Anyway, this is a very important topic, as you said rightly, Sumita, because postpartum urinary retention, we do come across very often and do not understand its significance. So please, someone will have to forward the slides. I just can't help it. I'm so sorry for this botheration.
Amit, keep
next.
moving
Please just be next.
Yeah.
Next, please. Yeah, so as I said, it's a common problem. And if you see various definitions, like Scali et al. Has said that the PUR is an inability to undergo spontaneous micturition within 12 hours after vaginal delivery. But others report that PUR is a symptom when you call it, when you require at least one catheterization within the first 24 hours postpartum. So depending on how people define it, the incidence has a great variation. As you can see, 0.18 to 47%. How do people define it? Next, please. So one very important thing which I just come across when I was making this presentation, although Yip et al. Described it in 1997, but that it is of three types: covert, overt, and persistent. Now, covert is the least bothersome because it is basically the increased post-void residual urine, that is more than 150. 150 is the acceptable one. So if it is there, or if it is asymptomatic and it is self-resolving, then it is covert. But if it is
the inability to urinate automatically 6 hours after vaginal delivery is there. See the change in definition here, they say 6 hours. And then, or the need for recatheterization 6 hours after catheter removal following uncomplicated cesarean section, or which requires treatment. They are included into the overt variety. And the third one is persistent, as the spellings, the definition says it. The word itself is explanatory, that it is inability to void spontaneously by the third postnatal day despite the use of intermittent urinary catheters. So this is how you have to understand, because the management will be different. Next slide, please. So now the causes can also be different in mechanic, physiological, which we all know. The hormonal changes are very affecting the bladder functions. But at the same time, during the delivery, the neurological factors also come across, like the trauma to the pelvic floor muscles and detrusor muscles is quite oftenly seen, because what happens, there is an over distension of nerve fibers, and that can lead to retention. And sometimes there can be some levator ani muscle avulsion, so that can be a mechanical cause. So any cause can be there. Next slide, please. So there, the risk factors, if you see, there are physiological changes, hormonal, as I said, progesterone levels increase. Epidural analgesia can also be a factor. Primiparous movement, so much apprehensive the first time. Vulval edema, episiotomy, second and third degree perineal tear, because patient is being painful and will spontaneously reflex retention will be there. Or the duration of the labor has increased, that is first to definition wise, first to second stage, more than 700 minutes. Fetal birth rate, if the fetus is of big size, or sometimes there are the instrumental deliveries like forceps, prolonged second stage, cesarean section after the program, non-progression of labor, intermittent catheterization. You all know, we do keep telling our resident, don't catheterize again. If you had to, then let it be there, but many times it happens. And absence of spontaneous voiding before leaving the delivery room. So in these cases, one has to be cautious, alert for the PUR. Next slide, please. So how do you identify? This is a very, very simple questionnaire. It is called VESI. V is ask the volume of the urine which she passed. Empty, has she been able to empty the bladder, feeling wise? What about the sensation? What about the stream? And was there any incontinence? So simple formula, remember the VESI. And if these 5 questions you ask the person, then you might be able to know that this person might be is a susceptible case for PUR. Next slide. Now, what can be the complications? If it persists and we are not able to diagnose timely, there can be, in serious cases, not the immediate one, denervation can be there, detrusor atony or failure can be there, bladder dysfunction, kidney failure, anuria, hydronephrosis, urinary bladder rupture, which is a very, rare thing, but one has to be careful. Urothelial lesions, long-term urogynecological disorders. Just to keep the, this is to complete the list, but basically more we are worried about bladder dysfunctions, hydronephrosis or detrusor atony, which will keep on causing the persistent PUR. Next slide, please. So how will you diagnose it? The International Incontinence Society says it. The simple methods are palpation, ultrasound, and then of course there can be other, again, I would say, as we are talking the academically, you have to know the catheter or cystoscope sometimes have to be done, or radiography has to be done, radio diagnosis can be used, but clinical preferable methods are palpation, catheterization and ultrasound. These are the 3 which will help us understand the problem. Next slide, please. So what in palpation? The only thing is, if you see, it is the simplest and of course invasive method. If just keep a hand, we have to train our residents or the obstetrician who's taking the round, don't forget to keep a hand on the abdomen, suprapubic area. Bimanual palpation can detect 200 ml of residual urine. But if you are doing single-handed, then at least that means, and bladder is palpable, meaning by there is a 300 ml of residual urine is there. So just to give some idea how much is the retention. Catheterization is of course both diagnostic as well as therapeutic, because it will relieve also. And usually it is done transurethral. Rarely you can say suprapubic is required, but basically it is the easiest way to. Ultrasonologically, if you have a ultrasound in labor room, easy to non-invasive method, and you can immediately. But ultrasonologically, there is no specific consensus that how much bladder volume is diagnostic of PVRBV. So next slide, please. Basically, most simple the management is the most important thing. We are diagnosing only for that. So the general measures which we all do, oral analgesia, because patient is most likely majority of the cases because of pain they are not able to pass. So if we give analgesic, oral or even injectable, they get relief in pain and they are able to do it. We also have to encourage the patient to stand up. Privacy is also very important. Some women are very that they cannot do it in ward, or they cannot do it on that on the bed. So you have to take help and take them to the toilet. Constipation, if they are constipated, has to be avoided, but if not possible, then catheterize, and because we have to eliminate the risk of denervation and bladder rupture. And clean intermittent self-catheterization is preferred to indwelling catheter. That is what is the important thing is. But self-catheterization is also admissible. This is what is, this statement, even I was thinking it should be done, said or not, but I've seen the various studies and the result, they say this, it is. Experience might be Manju ji and senior persons are there, they can of course see. Next slide, please. Yes. So basically, during pregnancy, preferred treatment is conservative. Usually it is transient, self-limiting. Data are not so good, but the protocol of voiding and routine measurement of PVR has been shown to be reduce the postpartum urinary retention. Routine screening is not required, but it has been seen that if there are a healthcare, but after the delivery, if sometimes risk factors are there, then it can be, these patients should be carefully taken. Next slide, please. So basically, now I'm coming to the second part, what about incontinence, that also occurs in postpartum period many a times, and this is, so ICS and International Urogynecology Association says that, of course, we know that the SUI, urge incontinence or mixed incontinence, we have 3 continents. But in most common type during pregnancy or in a postpartum period is the SUI. And that is what we are going to talk. And this range of prevalence is almost 19 to 75%. And if it is occurring during the pregnant antenatal period, then as gestation increases, the chances of increase. Well, definition all of us know, so I will not talk, but basic thing is it affects almost, we don't realize and sometimes ask such a detailed history, but it affects 40% of the women. And out of these, 77.5% women have these symptoms which are bothersome. And usually they do, it is understated because many times women do not come out with these smaller complaints, but it has a greater impact on social and psychological life, as we all know. Next slide, please. So this is what you can see, how the bladder is becoming, the sphincter is relaxing and it is becoming incontinent. Next slide. Because with the increase in intra-abdominal pressure. Now, I want to say one thing here, emphasizes that the mater pelvic floor muscle, just a minute, can I do this? There is a marker coming here, which is making me unable to see. Yes. So pelvic floor muscle weakness is the most important thing. This causes the urethral sphincter incompetence. And what happens? They're going to the increased mobility of the bladder, neck, and urethra. That is what is happening. Higher maternal weight triggers higher intra-abdominal pressures. Even smoking and constipations are independent factors for SUI also. The two studies I have quoted, what they want to say is that Tetinen in 2016 stated that vaginal delivery increases long-term SUI by 8% compared to cesarean section. That is one thing. Hutton et al. Also in 2018 found that women with a twin pregnancy and with no history of SUI in past, a planned cesarean section reduces the risk of SUI at 2-year postpartum compared with the vaginal delivery. I don't mean that I'm advocating this indication for that, but these are the findings which people have, the researchers have observed. Next slide, please. Another thing which was important was noted that SUI symptoms in the postpartum period were higher in those women who suffered from SUI symptoms pre-pregnancy compared with that who didn't have. If they had a mild symptoms during pregnancy, they will increase. That's what has been observed. Next. So basically pathogenesis, we have already almost talked. Overexpansion of the pelvic floor ligaments, muscles, and during the time of vaginal delivery, and especially the relaxation of the tissues which have been supporting the urinary bladder floor and the upper urethra. Side by side, there is a loss of collagen fibers, firmness, and because of that, there are some structural changes also in that area. Next slide. So the types, of course, it can be uncomplicated, it can be complicated. Next, how to differentiate with them. Now this slide you must be feeling looking busy, but it's not so difficult to understand. Basic thing is, if these symptoms of urgency, incomplete emptying, incontinence associated with retention, functional impairment, continuous leakage, recurrent infections, previous history of some surgery, radical or otherwise, prior anti-incontinent surgery or complex urethral surgery, or voiding symptoms or neurological or diseases associated. If anything is, these symptoms are there, then it will be called complicated. If there's nothing like that, then it is uncomplicated. Why it is important? When we are managing that, it becomes very important. Because if supposing we are dealing with a complicated and there is some associated disease, then of course, not only we have to manage SUI, we also have to manage the disease also. And if there are associated some recurrent urinary infections, we have to tackle the urinary infection also to a final, totally eradicated before we find the results of SUI. So that is why it is important to differentiate them. If this, of course, if there are symptoms of the prolapse or urethral mobility is absent or the residual volume is more, then again also this is a complicated, otherwise easier to deal with, uncomplicated. Next slide. So American College of Obstetrician and Gynecologists and even American Urogynecological Society say the recommendations are of the symptoms of uncomplicated SUIs. You can evaluate by the history, assessment of urethral mobility, physical examination, where specifically the demonstration of stress incontinence, urine analysis, and measurement of post-void urine residual value. So these 6 points, if you do, then you are able to clearly identify that it is uncomplicated. Next slide. Management of, I am not going to discuss here surgical. Don't be, I mean, no time for that. Just a touching up of the things. What are they? Medically, conservative treatment is the first line treatment. Always we prefer for that. And there comes the lifestyle changes. Pelvic floor muscle trainings. I will talk about this also in just one word, bladder trainings. Surgery is not considered unless the family is complete, because all of us know in the next vaginal delivery or pregnancy, the chances of failure will be there again. Surgery, you all know many of that, sling operations. And these days, again, the burst pulpo suspension has again gained the importance, because the synthetic slings and the tapes are now not considered good. So there are lists of that. So we will not talk about that. Next slide. Basically, the important points which I want to emphasize is a 2020 Cochrane review, which included 46 trials involving 832 women, indicated that structured pelvic floor muscle training in early pregnancy, incontinent women may prevent the onset of urinary incontinence in late pregnancy and postpartum. Mind the word incontinent women, but there is no evidence that PFMT reduces the urinary leakage in women who is already suffering from incontinence either during pregnancy or in the postpartum period. So when we are advising the patients about PFMT, we have to be very sure that already she was having the symptoms pre-pregnancy or not. That is the thing. Only if she was not having symptoms before, then she will be having the advantage. And if she was already incontinent, this will not give us advantage much. Now, guidelines which have been published by NICE, they do not recommend the use of intravaginal or intraurethral devices for the routine management of urinary incontinence women. They can, however, be used on a case-by-case basis if they provide benefit. So, just the various things I've touched upon. Next slide. Novel treatments, and they are laser treatment, duloxetine, and stem cell therapy. These are the few novel treatment. Duloxetine, we have been obstetricians all have been using. Stem cell is in a research period. Some studies say it is good, some say it's not much benefited. Laser is also a little, I mean, there are various still, but I like to go a little bit more because some idea, I liked it interesting. So I thought I'll share with it. Next slide, please. It can be a CO2 laser or it can be ER-YAG laser. Next. Next. These are the type of machines. Next, yes. So CO2 laser, basically, if you see what the thing is, they are all, they release the energy. And what those thermal energy, which is released there in the pelvic floor, that causes shrinking and tightening of the vaginal and pelvic floor tissues around the urethra. And that causes the support. And this is not very transient, as you will see in a few slides. Now, this CO2 laser is, the wavelength is quite good and it penetrates up to the depth of 50 to 125 micrometer. And whereas the ER-YAG laser penetrates up to 5 to 20. Basically, both of them are equally almost little variation. Next slide, please. So what is, I think you will understand this slide more, but I will tell you initially, and if need be, we'll repeat it. In phase 1, what is being done is, I hope I have a time of 2-3 minutes, Dr. Ranjana. Yeah, so phase 1, there is a full field handpiece with a 360-degree circular adapter, which is used to perform irradiation of the vaginal canal. 2 passes are given. In phase 2, a handpiece with a 90-degree angular adapter. First was a circular adapter, then with a 90-degree angular adapter, deliver the fractionated smooth beam perpendicularly to the anterior vaginal wall, and that will lift the bladder due to the shrinkage of anterior vaginal wall around that area. That's what we were talking. Now, once the second phase is completed, the laser, I'll show you in a video in a minute if I hope it goes turns. The laser speculum is removed from the vaginal canal and the laser energy is delivered to the mucosa of the vestibule and introitus by direct irradiation with fractionated smooth beam in 3 passes. So 2 passes of circular, then the angular, and then the direct irradiation. In FOGSI, the fractional handpiece and the straight shooting tip is used, consolidating the ligaments and connective tissue around the urethra directly, and it is also used to shrink the introitus of the vaginal canal. So that, I mean, the whole area has been covered, and that gives the quite good results. Next slide, please. So almost 1000 joule of energy is deposited to the vaginal mucosa in one cycle, and this raises the temperature to more than 60 degrees. First session is followed by a second session after 4 to 6 weeks, and third after the 6 months. The basic idea is that heat produced, the stimulation is there, and so the collagen formation is stimulated, and that is causes the remodeling, and the this is, I mean, it lasts up to 6 months. And as I'll tell you later, if maintenance therapy is given, it can continue for a benefit, can continue for a longer period. Next slide, please. This is the probe which I was talking. It is entered into the vaginal canal. And you see in the second diagram that it is perpendicularly, the beam is going into the submucosa area. Next slide. And this again, this is the angular probe. If you see the probe anterior part, it is angular one. Again, it is entering, the beam is entering into the epithelium lamina propria perpendicularly. Next slide. So the advantages are that procedure is painless, bloodless, stitchless, long lasting results, no need for anesthesia. Relatively easy, mild or even moderate cases are usually treated in 2 sessions. And of course, nobody, I mean, the first line, everybody wants non-invasive, non-surgical methods, everybody wants to try. Doesn't need any special pre-operative or post-operative precautions. No adverse events have been noted. Proven technology, they say it. And next slide, please. So I have actually kept the video in the last, because even if it doesn't work, at least let us complete the explanatory part. So the conclusion to this is the data suggests from the studies that 70% women are dry after 4 months. And studies have also proved that laser treatment using ER laser have shown that score improvement. This is a score ICIQQ, UI, SCF. There is a scoring system, and they have shown superior changes in the perinometer measurements and decrease in Q-tip angle. If you remember, we were doing a Q-tip angle. So that angle there is a decrease that is showing up, and better quality post-operatively, post 6 months treatment. Urological Society of India 2018 backed up the clinical research of intravaginal laser for management of SUI. And at present, only 15 companies in the world are making these things, but we further RCTs, and they are required. Meta-analysis and RCTs are not there. Next slide. There are few studies. If we have time, I can go with that, a little bit of idea. CO2 laser pixel is a safe and effective, and it, as I said, additional treatment, if you give with the maintenance, like adding with the medical treatment, then even 6 to 12 months benefit can be there. It is safe. The next slide, please. Again, the other studies, this was done, I'm not able to see the year, but these are all recent studies. But they say, of course, long-term, well-designed prospective studies are still needed, although presently they are showing that it is quite effective. Next slide. Again, this study, I think it was 2021 probably, and this also says when it is, but they say concluding remark is when a therapy is proposed to a patient, it is crucial to remember, friends, please, focus on this. Remember the level of evidence reported, and this is why larger RCTs evaluating the long-term effects of laser treatment are required to further investigate its potential harms and efficacy in the treatment. And we all know the cost factor is very, very important. So if, I mean, it is definitely good, but one has to look the advantage and disadvantage. SWOT analysis has to be done. So again, there is some studies have suggested the use. Next slide, please. And have those ideas that circular probe going how inside, it is delivering the passes, then taken out, then angular probe going, again delivering, then it is coming out, and then direct beam is given to the introitus. So one gets a feel and the visual read that how it is bugs.
But thank you, Kiran, for at least joining and giving your talk. Though we couldn't see you today.
Actually, it all happened. I couldn't do
but
it.
Never mind, we've seen you many times.
Yeah, obviously. I can, but the thing, I am able to see you somehow. I don't know. This desktop is new to me, so
okay.
The person can.
Yeah, your camera is not working, na? Your camera is not working.
Yeah. So
very crisp and clear talk. I am requesting chairperson, please give comments.
Very clear talk, Dr. Kiran, to the point. And definitely postpartum incontinence and retention is a very painful time also for the patient. And you have given very clear methods how to identify, how to treat. And after delivery, attendant, patient, all the birth attendants are all relaxed. And sometimes this is missed. So the take-home message is that we should make a protocol that the patient should either pass urine before leaving the labor room, or our staff and attendants should be sensitized that they should ask questions when she has passed, and so that long-term consequences are not there. And even SUI is a very painful, and I think women don't like to share, but you have given very good information about laser, and we are sorry to have missed the laser video. So thank you, Dr. Kiran. We have really enjoyed, and everybody has enjoyed your talk.
Thank you.
Ma'am, just a request, please share the link of that video with Amita, or you put it in the group.
I will do it.
Share with
It's
everyone.
a very short. I made very. I mean, I've just edited it. It's a very short one. And it's a clear cut. It is showing the process which I
It is a mild and
I'll share it.
Okay, thank you.
In mild SUI and moderate SUI, it is very helpful. Laser is very helpful. CO2 laser, because I have a CO2 laser. I have corrected so many patients, but in the severe SUI, it's very difficult with the laser. We have to go for the surgery.
Yeah, thank you, Ma, for and really that you will understand, and you can even explain it better that way. It is definitely.
Ma'am, I have a favorite machine.
Not the final
CO2
thing, but
pixel laser.
Yeah. Okay. Good.
Now,
Good.
if laser is not effective, then does it make any problem when the patient goes for surgery after laser failure? What is your experience?
No. I think Dr. Uma will also agree with it.
So it can be used as a step.
Sumita, what we are doing with the laser is only trying to stimulate the collagen fibers and make the urethral muscles around the urethra and anterior vagina more firmer. So in fact,
I hope planes are not lost. When we go for surgery after laser treatment, is there some study that whether the planes are lost, or is there some effect? Otherwise, patient can be told that.
I don't think so. I don't think there should be any problem.
It's not causing fibrosis. It is only increasing the collagen, so it is not going to change the anatomy.
But Sumita,
so later on you never know. Depends on the time. You have to find out. One has to find out.
Yeah, studies are not there. You are very right to point out.
So
thank you, Manjuji.
Thank you, Kiran ma'am.
Thank you.
Thank you, Kiran ma'am.
Before I
wonderful talk.
Please, all of you are here. I want you. We are all waiting for you in the month of May to Kanpur at the banks of Ganges.
Of course, we'll be there.
19, 20, 21st. And one very important thing, I hope you must have by now know, besides academic, we have planned a spiritual retreat. Although Sangam aapke yahan hai, बट हमारे पास भी गंगा है।
गंगा है।
तुम्हारे पास सिर्फ गंगा है, हमारे पास यमुना और सरस्वती भी है।
तो आपके पास तो बहुत कुछ है, बट जो हमारे पास गंगा जी है उनको हम डेफिनेटली उनका डिवाइन ब्लेसिंग लेना चाहते हैं।
बिल्कुल बिल्कुल बिल्कुल।
तो आप व्हाटएवर आपका सबका।
So after this academic piece, the time has come for formal vote of thanks. My heartfelt thanks to ICOG for always giving us points, and to Allahabad, Kanpur and Faizabad societies for holding our hands. My gratitude and wholehearted thanks to our chief guest, Dr. Gangadhar Sahoo sir, for his blessings and praising our society and his groundwork for ISOPARB and taking it forwards. My heartfelt thanks to the chairpersons, Professor Dr. Manju Varma, Dr. Chitra, Dr. Kanchan Sharma, Dr. Rita Mittal, Dr. Usha Goenka, Dr. Sumita Varma, for your graceful presence and valuable opinions. My gratitude and thanks to the speakers of today, Dr. Haresh Doshi sir, for his wonderful talk. We are always indebted to teachers like him. And my thanks to Ranjana Khanna ma'am for her crisp and clear talk and all the strength and direction she gives to all of us, and especially to me. Kiran ma'am for taking time from her busy schedule or giving this wonderful talk. We all are going back richer in knowledge. My thanks to Uma for we are very hardworking secretary of AOGS for always supporting and always helping me getting the ICOG points. Thank you, Uma, for all that. Thank you, Jagsonpal, Amit, Dr. Deepika, for always giving us technical support. And thank you, everyone. Thank you, delegates. Without you, you all have joined from far and wide from all over the India. And we are so very thankful that you all are joining for in this the festival day. And thank you so much. And with this, goodbye to everyone.
Good night.
I would like to wish everybody besides Akshaya Tritiya and Eid. Today is a day of Makni, who actually invented the wireless communication. So this is the day we have celebrated in his memory today.
Okay.
Great. Thank you.